For now, we move on to the next lecture. I will call upon Dr. Giorgio Peretti. He is the Director of Otorhinolaryngology at Genova San Martino University Hospital, Italy. He is a world leader in endoscopic laser surgery. He is a master of laryngeal conservative surgery and salvage laryngeal surgery.
Good morning, everybody. I would like to thank you a lot for your kind invitation. It's always a great pleasure to come here in India. I came many times. I like your country. I like also to share with you my experience in this field of head and neck surgery. My talk is focused on the indication and the oncological and functional outcome of laser surgery, transoral laser microsurgery in early laryngeal cancer. I show you the basis, the number, just to show where we are. And the next day I show some detail on the technique and the future perspective of transoral laser microsurgery. The indication of the transoral laser microsurgery are the early cancer. So particularly is, can I have this one? Is for the glottic cancer, is T1 involving one vocal cord, or T1B when the tumor involves both vocal cord and anterior commissure, and T1 of the supraglottic larynx. Of course, some T2, particularly transcommissural T2, extended to the supraglottis to the subglottis. The best indication is, my opinion, the T2 with superficial lateral extension to the supraglottis or subglottis, and even the T2 with minimal invasion of the muscle with impairment of vocal cord mobility. Of course, the T2 involving two subsites, and a very selected T3 in the glottic plane for invasion of the anterior paraglottic space, or cranially for the pre-epiglottic space, and for supraglottics, the selected T3 for minimal invasion of the paraglottic space. These are the indications that usually are confirmed in the literature. In fact, if you look at the result, we see amazing results in terms of local control and also the organ preservation, comparable or even better than the alternative therapeutic option. And my paper confirms also that these results are confirming the long-term follow-up after 20 years. And this is also reported by the China's paper with a follow-up of 20 years, or 10 years. The amazing result obtained in early glottic cancer push a little bit the indication to selective the intermediate stage cancer. Even if the selection of the patient is correct, we can obtain also for T3 glottic very good results in terms of organ preservation comparable to the open neck approach. Of course, we have a decrease in terms of local control, but the laser surgery gives you the possibility to salvage the recurrence, again with some conservative treatment, obtaining this very high rate of organ preservation. For the supraglottis, again, we have a good results, but the follow-up is not so long as in glottic cancer, because we start to use transoral laser microsurgery in supraglottic later than in glottic, And also the number of cases is less compared to glottic cancer. But even in this cohort of patients, we can obtain a very good result comparable to radiation therapy or open neck procedure. This is our work that show the results after 20 years, just to confirm the validity of this treatment in the cohort of more than 1,000 patients. Most of them are treated with CO2 laser alone, and only 9% need some adjuvant treatment in terms of radiotherapy, chemoradiotherapy, or open approach, or transoral laser total laryngectomy. In this case, we observe that in terms of disease survival and specific survival and organ preservation, the result remain stable after 10 and 20 years. We've observed only a significant decrease or organ preservation for T2 after 10 years and 20 years. But you can see that the results are still good after 10 and 20 years. It's interesting to point out that one of the advantages of laser microsurgery is the possibility to repeat the treatment, because it doesn't preclude any further option in case of recurrence. But we observe that if we perform more than 2 procedures for recurrence, we have some decrease in terms of organ preservation. And the repeat treatment doesn't influence the disease specific survival. That means that if we face with 2 or more than 2 recurrence, it's probably better to change the policy of your treatment and shift to another option, as for instance open approach or non-surgical option. But we don't impact negatively on disease-specific survival. This is an important message. Don't repeat many treatments. In case of salvage therapy, when we need some salvage treatment, we observe that radiotherapy, chemoradiotherapy negatively impact on disease-specific survival and increase the risk of bad result 6 times more. And in case of open partial horizontal laryngectomy for salvage surgery, we increase 3 times, more than 3 times, the possibility of lost your larynx. By contrast, if you use in selected cases laser for salvage surgery, of course we don't impact on both of these variables. But you have to take into account that the laser salvage surgery is indicated only in very selected cases. So finally, we can assume that the results, the good results that we obtain are stable in the longer term follow-up. That means that we can assume that laser is a gold standard for early glottic cancer with a very low complication rate and low need of additional treatment. The same results are reported from this Chinese experience with a longer-term follow-up, 10 years of follow-up, where the author compared the results between laser and open approach, and they didn't observe any statistical difference between the two procedures, just to confirm the validity of the TLM in long-term follow-up. But we try in this paper to divide this cohort of patients of more than 400 patients treated with TLM in different subcategories, just to understand what is the cause of recurrence in this cohort of patients. So we divide the heterogeneous group of T1 and T2 in 6 subcategories. In the first, we include only T1 involving one vocal cord, the T1 in the second involving the anterior commissure, in the third, the T2 involving superficially the supraglottis, subglottis, in the third, the T2 involving the vocal muscle with a deep invasion toward the deeper visceral spaces. In the fifth, the T3 involving the anterior paraglottic space, that means the entire muscle. And the sixth, the last one, the T2 involving in a vertical direction the anterior commissure, extended cranially toward the supraglottis and caudally toward the cricothyroid membrane. And we observe that if we talk about T2, we have very different results. The best indication are for T2A, that means T2 spreading superficially to the subglottis and to the subglottis. We have good results also for T2 with impairment of the vocal cord mobility. The worst category, and in my opinion, the weakest point of transoral laser microsurgery is transcommissural T2. That means that T2 that involve craniocaudally the anterior commissure, spreading to the preepiglottis place or to the subglottis. So these categories must be taken into account, and when we face with this kind of tumor, we have to select very, very well the patient, because we face with not good exposure in the majority of the cases, and you need very high skill to treat the patient. So in case of the involvement of anterior commissure with craniocaudal extension, my suggestion is to reserve the transoral treatment only in fragile or elderly patient. Otherwise, it's better to shift to other options, as for instance, open partial laryngectomy or even non-surgical treatment. So in conclusion, TOLS should be considered an ideal therapeutic strategy for T1, T2 glottic cancer, validated by long-term results. Of course, if disease specific survival and open organ preservation are well over the 90%, even after 10 and 20 years of follow-up, is a repeatable procedure, but you have to stop after more than 2 procedures. If you face with the third recurrence, maybe I suggest don't insist in this trail, but you have to change your policy. In case of needing salvage therapy, disease-specific survival can be negatively affected by radiotherapy or chemoradiation, organ preservation by open partial laryngectomy. So the total laryngectomy remains probably the best indication. From the functional point of view, I review different papers in the literature, and the results are more or less comparable if you look at the objective evaluation of the voice, but you have to take into account that when we compare functional vocal outcome between radiotherapy and laser surgery, you have to compare always partial chordectomy, as for instance subligamental chordectomy or transmuscular chordectomy. Of course, if you perform a total or extended chordectomy, the vocal outcomes are worse compared to the radiotherapy. So this comparison must be done only in case where we treated the patient with partial chordectomy, not total or extended chordectomy. And this paper is a whole paper, but show that, of course, the results decrease in relation to the type of chordectomy. So we have very good results comparable to the normal voice after subepithelial subligamental chordectomy. Of course, we have a worse result where we extended the resection to the deep layer of the muscle, the paraglottic space, because we cause an incompetence after the healing process. And the critical point is the anterior commissure, where we extend the resection to the anterior commissure. Of course, the vocal result will be worse. This is another comparison related to the supraglottic cancer. We compare in this cohort of patient treated with supraglottic laryngectomy performed by open approach and supraglottic laryngectomy performed with transoral approach. And we take into account different variables, issue. So we need the tracheotomy only in 2 patients, and with endoscopic approach. Of course, we've performed in all patients treated by open approach the tracheotomy. The feeding tube was needed for a mean of 5 days with TOLS, and with more than 2 weeks with open approach. And also the hospitalization time was significantly reduced between the two options. So just to underline that with open approach we reduce the complication, we reduce the morbidity, we reduce the hospitalization time. And based of this issue, we can also say that we spare a lot of money when we approach this patient with TLM, because in the Western country, laryngeal preservation protocol costs between 20,000 30,000 euro compared to the TOLPS procedure that costs 5,000 euro, because we can treat in the same section the patient and we can do diagnosis, biopsy, and treatment in one procedure alone. So this means that if we treat 100 cases per year, that is a normal number for a tertiary referral hospital, we can spare more than 1,500,000 euros. Thank you for your attention. I don't know if there is some question or some debate.
Excellent talk, Dr. Peretti. There are 5 minutes open for question and answer session. Anybody wants to?
Thank you, Professor Peretti, for a great lecture. We have gone through your papers regarding limits for transoral laser surgery for early glottic cancer. So you had mentioned that subglottic extension is a contraindication, and this lecture in the papers, but in the lecture we saw that some subglottic extension still can be considered for transoral laser surgery. Could you please explain which are those subglottic extension lesions where we can contemplate transoral laser surgeries?
Okay. Of course, for me the contraindication is subglottic extension more than 1 centimeter. That means when reach the cricothyroid membrane, but especially in the anterior part of the larynx, when the subglottic extension is transcommissural, so from the anterior commissure to the cricothyroid membrane. It's more acceptable when the extension is in the vocal cord, laterally to the vocal cord, without involving the anterior commissure. So it depends in which location is the subglottic extension. For sure is an absolute contraindication in the posterior part, in the posterior paraglottic space, and in the anterior commissure. In the middle portion of the vocal cord is still acceptable, but no more than 1 centimeter. And of course it depends how is the exposure. Of course you can face with extended lesion when you have a very good exposure. If you have a limited exposure or difficult exposure, it's better to change your policy.
Thank you. One question from you. As traditionally we have been told for supraglottic T1, T2, when you are doing a surgery, then you have to address the neck. So you all T1, T2, which you are doing laser, you do the neck, bilateral neck dissection?
Again, it depends of the location. If you have a central tumor, I perform bilateral. If I have a laterally tumor as a arioepiglottic fall, I limited the extension, the unilateral neck dissection in N0 patient. If I N plus patient, of course, I perform bilateral. In the elderly a fragile patient with, for instance, T1, I follow the patient with ultrasonography. If is a young patient, a fit patient, I perform simultaneously. Or sometimes you can delay also the neck dissection in order to reduce the morbidity, because if you delayed the neck dissection, you can avoid the tracheotomy after the procedure.
Professor, one last question from me. What's your experience regarding when salvage, post-radiation failure, TOLS?
The salvage therapy with laser.
With laser.
It depends how was the tumor in the beginning. If you had in the beginning, before the radiotherapy, for instance, T1 or T2 in glottic cancer without without anterior commissure involvement, you have a good exposure, I can treat the patient. Otherwise, if the tumor starts as T3 and now is T1, I don't perform any laser surgery for salvage. But you have to take in account one important message, that after radiation, the exposure becomes worse, because you have a fibrosis, you have a stiff neck, so it's not feasible more the time because the exposure is not good. So you have selected very carefully the patient for salvage treatment.
Thank you.
Yeah, sir, before you leave, please introduce yourself. Please introduce yourself.
I'm Dr. Mudit Agarwal.
Okay.
I was there with you with Dr. Rakesh Srivastav in Genoa.
Okay, okay.
I'm
I
talking
met a lot of you, but it's difficult to remember everybody.
So
Also because I came many times in Bangalore, in Lucknow, in Delhi, so.
yeah, may I request you to introduce yourself and then ask the question, please.
Dr. Venkatesh from Chennai.
What's
Sir,
Chennai? Okay.
how do you improve the visualization of the lesion in the anterior commissure and minimal subglottic extension? That is where we are not able to achieve a good negative margins. How to improve the visualization there?
The visualization, you mean?
Visualization.
Okay, you need in your armamentarium many types of laryngoscope because it's not enough just to have one laryngoscope. So you have to make a choice for the laryngoscope, the size, the shape of laryngoscope you use. And of course you need an assistant with a very hard control pressure, external control pressure. And also the position of the microscope and the head of the patient in Boyd-Jackson position is very important. But I give you a message. If you face with, as I show you, anterior commissure tumor extended to the subglottis, you need a lot of skill. It's not just you don't perform in the beginning of your learning curve, because even in a very expert hands, as I show you, the transcommissural tumor are the weakness point and of this kind of surgery.
Thank you. I'm Kaustubh from HCG Ahmedabad. Dr. Peretti, I have seen you working when I came there before 10 years, and the world has changed, and you have made large leaps into endoscopic laser surgery and open surgeries, and we are going to see your videos, we are going to see the importance of AI which you are bringing into the laryngology. But I want you to tell us from this lecture, what is an ideal time when you will see that type 3, 4 and 5 chordectomies patient should be evaluated for voice outcomes? What will be the optimum time when they will regain their optimal voice quality?
The optimal voice quality comparable to the normal voice you can obtain only after type 1 chordectomy, subepithelial chordectomy, but is reserved to very superficial lesion, leukoplakia, dysplasia, something like that. And after subligamental chordectomy, that in my opinion is the more common chordectomy when you face with T1 lesion. And in this case, you don't need to take a biopsy because you can perform in the one-stage procedure diagnosis treatment, because with bioendoscopy you can presume the histology and you can perform the resection in one procedure. Because after the healing process, the closure of the glottis is complete. So you have a good vibration, mucosal wave on the opposite side, and you have a complete closure of the glottis. After type 3, sometimes you have some incompetence because you have some decrease of the quality of voice, but I reserve the type 3 only in case of re-resection, not upfront procedure. For instance, you send me a patient with the biopsy already done, I'm obliged to make a deeper resection and to take out a little bit of muscle. So in this case, the quality of voice decreases. Of course, it decreases if I perform extended chordectomy. So the best solution to present in the preoperative counseling to the patient is the subligamental chordectomy. Is tumor limited to the middle third of the vocal cord without anterior commissure and without impairment of the vocal cord.
Yeah, but when the question is that when will the patient get optimal voice quality? How many months after or yeah? So
How
what would
many-
be the time for type 3, 4, 5?
How many time? How long you have to
Yes,
wait
yes.
to have a stable results?
Yeah.
At least the healing process takes 2 months, and after 2 months you can start with voice rehabilitation, and you have a stable result after 6 months.
Thank you. Thank you, sir.